Go ahead, fire it up. Yep. And we'll let Miss Locke, our 33-year recipient
Yes.
of the county, go ahead and take this
Quiet
meeting.
recipient, too.
Quiet recipient.
Okay. All right. Thanks, everyone, for coming. Let's just go around the table and say who we are. I'm Bobby Locke, the Director of Montezuma County Public Health.
I'm Katy Maxwell. I'm the Public Health Planner.
Schaefer, Assistant Director.
Amanda Mullen, County Medical Officer.
Stephen Tarnowski, I'm the Montezuma County Attorney.
Candelaria, Montezuma County Commissioner.
The Montezuma County Commissioner.
All right. Thank you. Approval of the minutes from September. Everybody good with them? No changes? Okay. Great. Okay. I think we're just going to first off go right in to our community health assessment. Katie's going to kind of go over some of the results of what it shows, and then we can discuss it and get some of your ideas maybe. So.
Yeah. So you may remember doing this, the community health assessment. And I want to say before I get into this a little bit more, what I'm going to tell you today is very preliminary results. We are just talking about kind of an overview, some of the highlights of the survey, and we'll be having a bigger report coming out later this year for more information about the survey and then also some secondary data that we get from the state. So I may not be able to answer everything today, but we want to at least start talking about it. Okay, so the survey was open from August through October of 2024. We had exactly 800 responses, which is very cool. I think we had 800 last time we did this. 800-ish. And I will say over 100 of those people only filled out the demographics portion, so we weren't able to use those ones, but we still got a lot of good information. It was in English and Spanish, and we shared it at over 75 locations. When I counted, I couldn't believe it, but explains why I was so exhausted those months. But really proud of getting it out to so many places. It was, the survey was primarily based on the social determinants of health model, and so I'll talk about that in a minute. But I just kind of wanted to give a reminder of why we do the survey. And that's because we are required by state statute since 2008, every county in the state of Colorado has to do a community health assessment and a public health improvement plan for the next 5 years. So in Montezuma County, we choose to have a local survey as a big part of that. We think having local data is super important. So that's a big part of our community health assessment. And then the next step this year, we'll be creating a public health improvement plan, and that will be our strategic plan for the health department for the next 5 years. Last time we did this, we had a big focus on behavioral health. So the survey this time, if you took it, you might remember there was a lot of focus on behavioral health. Actually, almost half of the survey was around that area. Okay, so I did want to talk a little bit about our collection process. And some of who responded to the survey. So we did overall pretty well, kind of meeting what the actual percentages of different demographic groups in our population. So we had 62% of the responses were from Cortez, and then we had smaller amounts, I won't go into each one, from Toyac, Pleasant View, Mangus, Lewis, Dolores. The actual percentage of Montezuma County residents that live in Cortez are 34%, so we're definitely overrepresented on Cortez. But we did a really good effort in trying to get them to get the surveys from other places as well. So I'm pretty happy with that. The age distribution is really great. We got pretty much all ages. The one we didn't do great with was 17 and under, but for obvious reasons, that's kind of a harder one to get. But other than that, did really great with age representation. We had a little bit more people married or cohabiting than actually live in the county, but not too bad there either. Same with education, high school and college. Fairly representative of our county. And We did have 68% female. The county is 50.3% female. We started at 80% female when we started collecting these. So we made some really intentional efforts to kind of get more males to respond. And from what I've seen, this is actually pretty good. It seems that females tend to respond to surveys more. I don't know why that is, but that's what we got. And then in terms of race and ethnicity, I would hand it to a family, if I was at an event, and of course the mom would fill it out, and I'd be like, hey, you could fill out one too, to the dad. And there was not always much interest there, but we tried. So thank you to those of you that did fill it out. Really appreciate it. It helps us get a representative sample and know what the needs are more accurately in our community. So in terms of race and ethnicity, we had 14% American Indian or Alaska Native. We had 17%, and the actual percentage in the county is 14%. And then again, kind of across the board, everything matches up really well with our actual demographics. So pretty pleased with that. That's all I'm going to say about that portion, but I wanted you to know kind of who was responding. And now I want to hand out this flyer. Thank you. Do you have a question?
I do have a question, because this is a community assessment, basically, survey, right?
Community health assessment geared to
Right.
around public health.
Right. So I haven't done the math here, but what's 800?
I did do the math.
What is the percentage?
It's 3% of the population.
3%. So we're going to make decisions based on 3% of the population? Okay, you're getting
No.
ready to tell me that. Okay, good. Because that's what I struggle with.
We
When make-
compile this because this is the local voice, which is super important.
Mm-hmm.
But when Katy was referencing how we're going to have other data that we're going to blend in with this, it's looking at CDPHE's databases, but it's still a broad base of information that we can compile results. If things align, if what the state's showing is what we're showing, and they correlate, then it's valuable to go off of our local voice.
And
So,
correct, I understand that, but I'll wait, because I didn't
yeah,
hear that number. tossed out, but
nothing's
I'm knowing
made
that's a very
from
small
just,
number
yeah,
of the
exactly.
population.
And
Yeah.
that's basically what we had last time, the same percentage as last time, but actually we had probably less population size a little bit 5 years ago when we did this. So, but yeah, I mean, we would never make any decisions just based on 3%, but it is going to, the trends and the comparisons are what we are going to go off of. Yeah.
And I will say you can get a statistically valid sample that's pretty small. We don't generally do that in public health planning just because it's pretty, please hand those off. It's a pretty intensive process, and we don't have like statisticians. So I wouldn't say this is necessarily a completely representative sample statistically, but we try to make it as close as we can. And I will also add that 800 is like triple what most counties get, especially rural counties in the state of Colorado. So we're working with pretty good numbers in terms of averages there. Okay. So looking at this flyer, I kind of went over the beginning already about some of the background information of the survey, when it was, how many responses we had, where we shared it. And the locations were a combination of having paper flyers at places like libraries, medical clinics, and then it also included over 15 in-person events where we tabled, and then also locations having flyers up at liquor stores, just so many places I can't even think right now. But it was a broad spectrum we tried to get across the county. The social determinants of health are kind of the bullet points in the middle of that top white box, and that's what our advisory committee, that's how we designed the survey, was around the social determinants of health. And those ones are healthcare access and quality. How is our healthcare access and quality? What do people feel about that? How do people feel about their neighborhood and the built environment around them? How do people feel about the social and community context? And then we have economic stability and community strengths. So this flyer, again, I said these are highlights. So this is just the number one answers for questions in each category. And I'll just go ahead and go through them, and then we can discuss it a little bit more. So we had 65% of people say that mental health was the most important issue to them out of 13 health issues listed. We had 38% of people saying they didn't know where to go for help to prevent substance use. We had 69% of people say lack of affordable quality housing was the most important neighborhood issue to them. And then we asked, what has stopped you from getting health care or mental health care when needed? And 49% of people said no appointment available or takes too long. And again, these are the number one answers in each of these questions. On the other side, we have a really great statistic that 65% of people reported that their mental health was good or very good. We had 53% of people say that child abuse or neglect prevention was the most important social or community issue to them. And then we had 84% of people say that lower food costs are the main need related to food access in our community. And the interesting thing about that is 84% is the highest percentage we had on any answer. So that was hugely important to our community. And then we did ask about some positives. What are our biggest community strengths and assets? And these are the top 3 answers. People were able to select 3. We had outdoor recreation opportunities, 70%, natural beauty, 64, and weather, 30. So thank you to everyone that participated in the survey. And like I said, this is a work in progress, and we're going to be doing more analysis of the data that we have. Let me see if there was anything. Oh, we had one at the end that was open-ended for people to write in their responses. And did I leave it? Let's see. I might have left it.
One thing I'd like to say is I'd like to say thank you to all of the community partners, businesses, liquor stores, marijuana stores. We went everywhere and distributed these all over the place, and it took a village to get those 75 places represented. So thank you to the community for doing that, and of course, like you said, thank you to the people who filled it out, because that's the only way we know the voice. So it was a great effort.
Yeah,
so.
And the organizations that were involved are part of our advisory committee also had huge lifts. So it really, and the whole health department helped out, which I'm super grateful for. So I did just want to quickly comment on, we had 133 open-ended responses that people put in the last question at the end, which was, are there any resources that we're missing in our community? People interpreted that one in a lot of ways, but I'll just mention some highlights there. The number one thing we came across was health and substance abuse services. 6 people mentioned that in their open-ended answers. We had people asking for rehab centers, inpatient care for addiction, a desire for more mental health services, access to birth control and sex education, and we had a lot of desire for affordable health care and doctors who stay in the community. We had a section on youth and family services. People were really interested in youth activities. And then, of course, childcare, more childcare and preschool options. Transportation and accessibility was another one. Public transportation came up 7 times. And then affordable housing and community support. Affordable housing came up 9 times. People also expressed interest in community building activities that could foster stronger social ties within the community, more public spaces, and then we had education and job opportunities. 7 people mentioned a desire for better schooling systems, and then we had environmental and community infrastructure. People mentioned some environmental concerns, access to healthy food, and public safety. And then some just kind of miscellaneous things, but I wanted to mention those as well. So that's the information we got from our community and kind of a preliminary look at it. And I just wanted to open up to questions or discussion about that.
So once we gather this data, okay, then what do we do with it? Because that's
So,
always the question that everybody asks us. You can get all kinds of data, but once you have it, what do you do with it? Because everything on here, and to me, you know, because of housing, that's one of the issues that they put on here. 69%, we are dealing with that on a daily basis and have been since I started. So for 6 years, and the only thing, and here again, I'm going to kind of get a little irritated with the state, is because we talk about affordable housing on one side of our mouth, and then we put so many codes and standards on the other side, we're going backwards. We're creating higher cost, and we're not achieving anything that we're trying to do. So once we have this data, how do we use it? To good, to benefit. Because we have data right now, and we're using it, in my opinion, we're not doing anything to help the issues or the problems. We're just gathering data. So now what do we do with it? There's my question.
So I'll just give an example historically what we did with the last round. So when the last time we did this assessment, and mental health, like behavioral health was the overarching need, right? So where we went with that was it enabled us to go, and we got the CNC grant, which is the suicide prevention model that we have in the health department. It's allowed us to do the Rise Walk, and we're in year 3 of that? So I mean, there's things like that are sort of grassroots public health strategies that we can use, obtain, wrap our arms around, and put embedded into the community. So public health is not going to build a housing project that is low income, okay? That is not possible. However, we can support Pinion Project, who has a housing grant, who has housing issues that they have, been expanding upon. So some of these pieces, it's going to look like we're not doing anything, but we are, because we're kind of behind the scenes on, like a housing issue, for instance, because we are not building housing projects. But some of these other things, what happens when you are houseless? You have other needs, food, right? Health. All these things that are also embedded in here, we can help with those things. And we, depending on where we go with our advisory board, and if we're going to have key leader meetings, or we haven't and I'm not going to say what we're doing because it's a group effort on what we're going to do, how we're going to move this forward. But that's how it's built upon, and then we would seek funding for whatever it is that we are going to task ourselves with. We're not going to be able to do 10 things. It's not going to happen, Sometimes multiple things are under one thing, one topic, and it can be helped that way. But we're not going to go for 10 different grants. That's not going to happen. I mean, I doubt it anyway. So I don't know. We don't know, like Katie was saying, we don't really know exactly what we're going to focus on, but we know what we are capable of doing in public health and embedding that into our public health and how we can serve the community. So it's not a cut and dry black and white answer I can give you on what we're going to do with it.
I understand that. I will tell you the one thing that I do like is the 65%, which is for good and or very good for your mental health. Because I think, and it depends on where you reside and what groups you run in, but I mean, most of the people that I see and talk to on a daily basis, and I know I'm not where you're at, you're in a different line of work, where I used to be, but they're good. I mean, they feel good, they're healthy, they're typically, life is good. So that's a good number. I mean, I like to see that kind of number, because that's,
and I would agree with that. It's also perspective, too, right? It's my idea of what my mental health is probably not the same as what you think your idea of good mental health is. So these are 65% of the population think that they have good mental health,
Yes.
which is great.
From the last survey?
Well, the thing is, we didn't ask this question on the last survey.
Right.
So
we don't have.
Yeah.
Okay. the ability to compare.
Yeah, but I love the question about the data and what do we do with it, because the data is only as good as whatever initiatives come out of it. And I think Bobby kind of explained this in, like, the way that I see it is we have a very specific purpose for this survey because we have our public health improvement plan, and not just because it's a state mandate, but because it makes sense to create our next 5-year plan out of what our community tells us their needs are. But it also is a community survey. Like Bobby said, we may not be addressing housing, but there are organizations in the community that do. And so we want this to be able to be shared and utilized by anyone in the community, including yourselves. If there's information in here that you can utilize, this is a wonderful opportunity to have a snapshot of the community. So yeah, I'm excited about the information. I'm excited to dive into it a little bit more and come up with our public health improvement plan.
And the public health improvement plan is a public document, and it's meant for this whole community to utilize, when they are seeking certain funding or certain needs. It's just like oh my gosh, I'm drawing a blank on the child health assessment that's done, Healthy Kids Colorado survey, all those types of things. This is kind of a similar tool that people can utilize when they're going for a particular topic of funding to help our community. It helps prove the need. So.
Yeah. Is there anything you would like to see happen from it?
I mean, just me personally looking at it, of the questions that we have here in front of us, the 6 questions basically. Obviously, the last one, the lower food costs, kind of really out of our control. Other than maybe helping people understand that they can grow their own foods no matter where they're at, whether they're in the city, in the county. I think that's kind of education that we can go back to the Victory Gardens or community gardens, whatever they used to call them. Because that does lower food costs.
Yes.
And it's healthier. It's just better. I think that's something that we could do with public health in a quick and easy manner that's education, because I mean, you can grow a lot in a little bitty space, and
Yeah.
a lot of people can do that on their own.
Yeah.
I think that would be critical to me, and that was 84%. That was the highest that you had on there. The other one for me, the 65%, is to encourage people to get outside more. I think, I don't know what your guys' opinions are, but I think this whole working from home every day is leaving people sad, lonely. I think they're headed down a path of, I mean, future destruction, really, because then they kind of turn into, I don't want to say a hermit, but they don't have any interaction. We interact, we're people. We were built to have interaction.
Yeah.
I think that's just something that we could get out there more with the education. It doesn't cost a lot of money to do that. It's a good number. Don't get me wrong. I like the 65%, but I think it could get higher with not a lot of help. I'll leave the child abuse alone because I have an opinion on that, but I'll leave that just as an opinion. I will not opine today.
Well, I think both of the things you mentioned are the perfect example of how public health or other organizations can do things to try and address these issues. Even if we can't lower the cost of food, we can talk about alternatives. So, exactly.
Correct. And I realize that you can't fix everything, like the housing, and I understand that. Those are issues that we've been working on now for 6 years, and we haven't, I don't think we've gotten anywhere.
We haven't made a deal.
And it's kind of, it's hard on our side to see all these needs of the community, but we can't really, we can't fix it. We can't cure it. We don't have a pill or a shot or something. I mean, it just doesn't exist. And we see these costs continually to go up. And it's like, where does that stop? I would hate to be a young kid nowadays trying to buy a house, you know?
Yep.
But anyway, that's all I'll stop there.
Any other thoughts or questions?
I don't know if you can answer this, but you mentioned that part of what's going to happen soon or in the near future is that somehow this is going to be integrated with information from the state. Are you in a position to say anything about how our local survey either fits into the overall trends or things that are different about our area based on the survey?
Well, I haven't delved into the state data on all of this, but I've looked at some of it, and I will say the mental health correlates pretty well. It's actually, from what I've seen, our reporting on mental health here, the 65% is a little bit better than I think what they've captured at the state level. And then a lot of the state things we will get are they're not going to be how do I describe that? They're like the rates of diabetes and things like that. So it'll be a
Right.
little bit different than our local data.
Yeah, because this is the individual's voice filling this out on themselves and what they see in the community, right? What the state's using is medical diagnoses, information from hospitals, like they're using those kinds of data pieces and data points to put into it. Child abuse, child fatality, cancer results, all those things are coming from medical, if you will, not what the individuals are saying. So that's why it's good to try to look at them, compare them, align them. But trending wise, like when you look at these, I believe that these trends do match what the state shows. Nothing in here is like out in left field for comparing and looking at the state data. So yeah, I think we're on track. I do think that the results are skewed depending on how the data is compiled, right? I mean, because if you're doing it on yourself, that looks different than what your medical might look like. So, yeah. Anyway, but yeah, I mean, we will, like we're going to have the state compile exactly what we want them to help us with, but we're going to look at the data on the state dashboards and compare, and then decide, does this correlate? If it does, then we're probably going to use this. If this is a priority that our community sees as an issue for us, that's valuable, and we're going to run with that, But if it doesn't appear that the data supports that that's an issue, we might, let's really look at this a little bit deeper before we launch anything. So, and we can totally, as we progress along this, at our next Board of Health meeting, we can give you an update where we are with things. I mean, this is a process. This isn't something that's going to be done in 6 months and we're, check that box, we're done. No, this is a 5-year process. So, it's not going to be over by December 31st. So, okay.
And you may have said this too, but you mentioned, I think, that there are other partners involved in creating the health improvement plan?
Yes, well, so our stakeholders, basically, we had like leadership from different organizations that we felt would be kind of represent all populations as best we could. We had someone who represented food issues. We had someone who represented families and housing. We had someone who represented child welfare, adult welfare. We had someone who represented behavioral health. So, and then us, public health. So we felt like that was kind of trying to catch all the people that would help us guide what that survey looked like, because we had to come up with what the survey looked like, which everyone who did one sold the survey. And that was based upon what the stakeholders developed. So it actually was, I think it was very well done, and it encompassed a lot of different things. Now it's how do we interpret it and how do we put it into play? Mm-hmm. That's where we are.
And the public health improvement plan will be a collaborative process too, because public health is collaborative and we can't do any of this on our own. So even though these initiatives, some of them will be housed at the health department, some of them might be at other organizations, or there might be partnerships. So yeah, it happens collectively, and that makes it hard to answer questions in the meantime because we don't know what the collective's going to decide. So.
Thanks.
No, I was just going to say this data is compiled and stored somewhere at the state level, and we can choose to do something different than what the state wants us to do if it fits better in our community. So we do have a little bit of freedom there, but this, as long as this correlates with what the state is doing, it'll probably drive where we go with it, for the most part.
And that is a really good point, Laurel, because the state, CDPHE does not tell us what we are going to work on as a result from this survey. This is a local decision of how we move this forward. We may have to partner with the state if we're looking for funding for a specific something, but they don't tell us how we drive this, so.
And I'll add that some counties, some local health departments don't even do a local survey. They just depend on the state data. So we make a very intentional decision here to really include that community voice. We think that's really important. So that's kind of how we do our process here. And I'm the first public health planner, the first person we've had in this role in this county, but I know that tradition of including the community voice is carried over from previous assessments, so. Okay, thank you.
And I'll comment though that this does pretty much line up with a lot of what I see here.
Okay, great.
Some of the comments you had about the activities for kids and families, like I've seen that too. Not as many structured things that are kid friendly. I hear a lot about the lack of affordable housing, and a lot of these are nationwide problems, but
Right.
it is something that I do see in clinic and I see in my patient panel too.
Great.
So.
That's good to hear. Thanks.
Okay, so I think we'll move on to our department update. Let's start with, and I didn't write each individual thing down here, but the first thing we wanted to bring up to you guys and just kind of bounce it off to make sure you're on the same page with us. Last year, I don't remember the date when it actually happened, but we had a discussion with Matt Lindsay in regards to the licensing for the ambulances, and the state had changed it in statute that it could be done at the state level or it could be kept locally. And I'm pretty sure that you all decided you wanted to keep it locally and do what we've been doing. Great. Then the state sent a letter to Matt. And then Matt has been communicating with us about this too. And so basically what the state wants to do, and Laurel's got all these copies there, but it's all going to be the same, kept locally, but they are structuring it so that the inspection piece, which our medical officer does the inspections of the ambulances yearly, historically, with this new process, that inspection would only have to take place but every 2 years. So the licensing would basically be good for 2 years. So, and that way we're aligning, yes, we're doing it locally, but we're going to align with what the state's kind of doing. And that's kind of what Matt was, his impression. I'm good with it. Dr. Mullen, and we talked with her earlier, she's good with it. But I want to make sure that you all understand that it's not being done yearly, those inspections. We would go to every other year. So.
That one seems pretty easy.
Yeah.
If it's 2 years and it meets all the criteria.
Right.
Because if anything changes significantly, we're going to get something passed down to
Right.
us
And
immediately
I mean,
anyway, so.
they do a wonderful job, Matt and Scott and all the crew over there, they take care of everything. They got the top of the line, everything. And so it's not like, we know them, we work with them. It's not like there's businesses outside of there that we don't know that are doing this work.
Mm-hmm.
So I feel like the relationship's there. I don't foresee a problem with it, but I wanted to bring it to you all, let you know that that's kind of what we're thinking of doing and making sure that sounded okay to you.
Yeah, I don't have any issues
Okay.
with that.
Laurel, was there any pieces of that you want to add?
Add that we are going to be shifting to a state fiscal year, and so we'll get the inspections done before June 30th, and then they'll send off, once we do our paperwork, then it goes to the state, and then they get their paperwork from the state. So it'll be a state fiscal year instead of what we usually do, which is a regular calendar fiscal year. So the next time we'll do it is in 2026. So they're due July 1st of 2026, so we'll get on it before then.
Thank you for that input. So the next thing I have on my list is, drum roll, so our medical officer is moving on, and I'm going to just let Dr. Mullen speak to that, and we will be in search for a new medical officer.
So my husband and I took jobs on the western part of Nebraska. It was a decision that we didn't take lightly. It's been a long time we thought about it, but it's going to be a good move for our family. We're going to just work outpatient and not do the inpatient part of our jobs that we're doing here. It took us a long time to make that decision, but it's going to be better for us. And then it puts us a little bit closer to the Denver airport where I can fly back east to see my family easier. So that's how we decided it. We're going to keep our house here, so we're going to come back and forth a little bit, but I will step down as county medical officer once we find someone else. I'm not going to step down the second I move, but I'm going to help try to find someone else to take over my role, and I am sad to leave the community, but excited for a new opportunity for my family. We're going to be leaving at the beginning part of April is when we're moving, so it's coming up here soon.
And Dr. Mullen has been amazing to work with. She's been a wonderful medical officer. We all wish her well, her and Jay, Dr. Anderson, excuse me. But yeah, I mean, life has a way of sending us messages, and we have to listen to those messages. So I feel confident that Dr. Mullen is going to help us in these decisions of who we're going to have as our future medical officer. And a nice transition will be had. So I'm good with it, and I'm sad to see her go, but I'm happy for both of them. So.
Congratulations. I mean, best wishes in the future and where you go, and thank you for what you have done. Appreciate it.
Yeah.
Yeah, sad to see you go, but I realize that you have to do what's right
Yeah.
for you too.
Yeah.
Dr. Aiken's sufficiently bored by that.
You know, the thought crossed my mind, I should text him and say, can you reinstate your medical license?
We've got a few people in mind too that I already texted
Yeah,
today.
okay, good,
That are
good.
very interested
Yeah.
and very qualified.
So I think we'll be,
Yeah.
we'll be in good hands. Dr. Mullen's not going to leave us in anything less than that. I know it.
I'll still be at the next Board of Health meeting.
Yeah,
I'm not gone yet.
And that's not an April Fool's joke,
That's-
because it's on April Fool's.
I'll put it in my calendar.
For real.
Moving to Nebraska, western part of Nebraska during tornado season.
Single wide trailer too.
Oh, they love those.
Have you ever watched, you've all seen Cars, right?
Yeah.
The last, with Mater in the helicopter? Remember what he says? He's happier than, oh my gosh. Yeah, trailer in a tornado park. Like that. Anyway, you'll have to look it up.
Oh my God.
Wizard of Oz better than Cars, but
Okay, so what I have next on here to talk about is just basically our communicable disease update. Give you guys an idea of what's going on in our community. Overall, it's actually been fairly quiet, with the exception of a couple things. So as far as our Narcan and fentanyl distribution, it's really running average numbers. It's gone up a little bit, but it's not dramatic. Our fentanyl test strips we've given out to 100 individuals, and our community partners 1,150. So that's 1,250 fentanyl test strips out our doors. Narcan kits continually climb. We've given out 147 Narcan to the community and some community partners. So we're grateful that people are utilizing these tools, for sure. As far as communicable, well, I'll just go into animal bites. There's 14, and that really runs 13, 14, 15. That seems to be, for the quarter, seems to be the average numbers for animal bites. As far as COVID goes, slight uptick, but as of January 14th, there have been 104 cases for the quarter. Our STIs, they all have climbed in numbers. So we are seeing more of syphilis, chlamydia, and gonorrhea. Today actually starts our agreement that we went into with the state with street medicine. So Dr. Atwell, who came to a previous Board of Health meeting and shared with us all the things that she does. One of the things we're partnering with them and CDPHE for those who she treats and serves who are uninsured by basically, what do I want to say? They're not tribal members. So, but they could be partners of tribal members who need to be treated. So we're showing signs and symptoms of a disease process. So we have the ability now for her to collect the specimens, and we will handle it through the hospital lab and get it sent up to the state lab, and we'll be able to do that for free. So it's an agreement we went into with the state on this, and it's not an unlimited amount. We have to track every one, and we will ask for more of these as we run out. But it starts today. So we will see how far we get with it, and then when we need to, we'll negotiate for some more funding to do it. So that is a real plus for our community, because that's really the only way, if you properly treat, it's the only way you're going to make a shift in some of these numbers. So, and feel free, Dr. Mullen, to pipe in if you.
I'm seeing.
Okay. Yeah. One thing, we did not have a documented West Nile case for our county in 2024. So that's good. That's good. Of course, we barely have any moisture now, so we probably won't again. Anyway, okay, let's see. That was bad. Yeah, I know. I was in the 2-hour wait out there. Yeah, yeah. So HPI, just a little, so HPI is the influenza A, H5N1 that you've been hearing about for a while. So on January 6th of this year, the Louisiana Department of Health reported the first human death in the United States related to this outbreak. There have been 66 human cases and 1 death reported since 2024. And that's throughout the nation. I'm not saying Colorado, that's throughout the nation. Currently, there are no affected commercial dairies or poultry facilities in the state of Colorado. But the wild birds and animals and sporadic wild backyard flocks continue to test positive for it. CDPHE and whatever the local public health agency is helps do the monitoring of the individuals that were exposed to the animals. And Colorado Parks and Wildlife staff all collect carcasses. The folks that collect the carcasses are also being currently monitored just because they're constantly exposed to the disease. So CDPHE does the monitoring on them. Cooking poultry, eggs, and beef to the appropriate temps is the best way to kill the virus and the bacteria. So people need to cook their food and not eat raw. So that's about all I have to say about HPI. Any questions about that? No? Okay. Norovirus. We currently experiencing a higher than usual number of norovirus outbreaks. Between September 1st and December 17th of 2024, there were 135 outbreaks caused by norovirus. And they typically occur in long-term facilities, like nursing homes, assisted living, schools, and child cares are where you see the big pockets of outbreaks for norovirus. And I know that people call it the flu or the stomach bug, but the norovirus is not the flu. They're two separate things. So one is GI. Norovirus is really contagious and it causes the vomiting and the diarrhea. But people call it like the stomach flu or the stomach bug, but they're not the same. They're not the flu. Norovirus is the leading cause of outbreaks from contaminated food in the United States. And so some of the foods that tend to get infected with it, if you will, are leafy greens, fresh fruits, and shellfish. So as of January 14th, and I know you probably all know somebody who has had this thing that's going around, but as of January 14th, there have been no reported cases in this county. People sure seem like they're sick with it, but they're clearly not getting tested for it. So, no documented cases yet. I thought that was interesting. So, but anyway, wash your hands. That's like wash your hands, and you wash your hands before you eat. So,
And
go ahead.
before you prepare food. But a lot of these we're not necessarily testing too, because it is just supportive care. And
Right.
by the time
Right.
I see someone, they're getting better. So that's
Yeah.
going to be a hard thing to keep track
It
of
is. It
necessarily.
is. It really, what happens, I think, with the more likely area that we get is when there's an outbreak at a child care center, a nursing home, and you got all of a sudden you got 25 residents that are having vomiting and diarrhea. Okay, there's something going on there, right? So then they test everybody, and that's when that's why it's like the outbreaks are noted, but the individual cases that you get, because usually 2-3 days you're fine, you're over it. It's just, kind of treat the symptoms and try not to contaminate others that you live with. So, but washing your hands, you go to the store, you come back, you put your groceries away, wash your hands before you start eating, wash your hands, wash your hands, wash your hands. 20 seconds, wash your hands. So that's really the best way to keep from getting it. And that means with soap and water, not hand sanitizer. So, no, you don't. So what other good advice do you have, Dr. Mullen, besides that?
I agree with that. Wash your hands. Prepare your food accordingly. Those are the two biggest things. If you know someone's sick, definitely isolate. I mean, if you pick your nose, wash your hands.
Yeah, there you go.
Before and after. I am curious about the leafy greens. You're getting
Yeah.
it from leafy greens, so
Yeah.
you just need to make sure you're washing your
Yeah.
Okay.
Yeah, you need to wash them. Yeah.
with soap.
No, no.
Just
No,
kidding.
Just rinse them off. Rinse them off. Because you eat it raw. Now, if you cook it, it's different. But, lettuce, you put in your salad. I know that they have the lettuce that says it's washed. I still wash my own lettuce. I don't not wash my lettuce, even if it's washed. I wash it again, because then I know I do it.
Life, so I don't, but I know what I'm risking.
But yeah, if you just rinse that off, you'd be fine. But cooking your food is super important. So anyway, I know there's a lot of people who eat their food, pretty raw, but again, there's risk involved with that. So anyway, any questions about norovirus or any of the things I went over as far as communicables for our county? Okay.
Week, we're healthy, we're old, we're the old steel model. We're pretty healthy.
Norovirus already.
Exactly.
So.
You can't. We lived through it. You can't kill us off now.
I'm not going to touch that with a 10-foot pole, okay? Okay. I don't necessarily have anything else unless someone else has a question. Anything we didn't talk about? You can think of? Okay. Stephen, do you have anything? I mean, this is your first Board of Health meeting. We're
Yeah.
glad you're here. Yeah.
Thank you. Yeah, no, I don't have too much to add. Thanks for all the information. Yeah.
Yeah, yep. We're glad you're here. And I don't have anything else. Our next meeting is April Fool's Day. And Dr. Mullen will join us. So thank you all for coming, and we'll see you next quarter.